I'll start. Okay. Hello, class. I'm Kaya Mitchell, and my partners Nikita Chris and Logan Dominique are coming to you today to present our project on predicting healthcare costs using linear regression. The United States spends an upwards of $4 trillion on healthcare in fiscal year 2020. This expenditure breaks down to around $10,500 per resident in the United States. However, the cost per person varies widely. People with major health issues skew the data significantly, raising the average, where the typical patient cost is significantly lower than $10,500, depending on the demographic group. Major factors driving these costs include hospital visits, medical conditions that require controller medications, and repeated doctor visits. The ability to predict costs allows families and people to better plan their budgets or insurances and avoid unexpected medical expenses and debt. So determining which factors influence healthcare costs and if there is a linear relationship with them will allow patients to better understand their own potential healthcare costs and expenditures. Data exists that groups some demographic trends with healthcare costs. It does not take two sample t-tests to determine the potential significance of the data points and does not apply linear regression to determine a possible correlation. Standard mean, median mode, outlier removal, histogram, and additional biostatistic analysis will help understand the underlying data. And two sample t-tests will be required to determine if a significant difference exists between two sample means, and linear regression to determine the coefficient of determination and if a strong correlation exists for healthcare costs and demographic factors. The graph on the left reflects how healthcare costs vary by geographical location, specifically state by state. These differences can be as minute as from county to county. So general geographic demographics such as Northeast, Southwest, etc. will give a general sense of healthcare costs for the area, but will not be accurate for all patients. The top right graph shows that women typically spend more than men on healthcare. This can be up to twice as much depending on the year. However, when we did our own analyzation, we found that this difference wasn't as big. The bottom graph shows that healthcare spending can be stratified into 5 distinct age groups from 0 to 5, 5 to 17, 18 to 45, 45 to 64, and 65 and up. This distribution is not normal, but ages lower than 45 spend significantly less than ages greater than 45. However, our data will reflect only ages between 18 to 64, therefore neglecting patients younger than 18 and older than 65. So the Center for Medicare and Medicaid provide the healthcare cost differences by geographical locations, and they did this by collecting data and publications across different demographics. However, they provided no data analysis. The New York Times did a comparative mean of costs across geographic locations, where they also lacked linear regression or interpretation of the data analysis. And the U.S. Department of Health and Human Services did a comparative mean of costs across demographic location by age, but they also lacked the statistical testing in the comparisons presented. And registered nursing did a presentation and evaluation of the HHS data, and they also lacked linear regression and statistical testing. A linear regression and two sample t-test analysis of the data previously gathered would offer a better understanding of the linear relationship between demographic factors and healthcare costs for families and individuals. So this is our data descriptions, where the major demographic factors that impact healthcare expenditure are age, gender, pre-existing conditions, and geographic location. Age is a classification which tells you how many years someone has lived, which is often grouped into children from 0 to 12, teens 13 to 18, young adults 19 to 45, and older adults 45 to 65, and with seniors 65 and older. But as I stated earlier, our groups will only be representing ages 18 through 64. Sex is a gender that people are assigned with at birth, and is categorical with two options, either male or female. BMI is known as a body mass index and is a number calculated by dividing a person's weight into kilograms by their height in meters squared. It is clinically standard to use BMI as an indication of health and as an indicator of whether someone is overweight or healthy. Children is an indication of how many children that person has had that are covered by insurance, and smokers here is presented as a binary of yes or no, which indicates whether or not a person regularly smokes in their life, and region depicts what corner of the United States that the person resides in, and charges depict the cost in healthcare that person incurs in 1 year. And this is our work plan for which we've applied to analyze the data just described earlier. Where this slide here just shows our general workflow, where the left side reflects the data analysis, which is just a general method in order to analyze the data, where the right side is more specific to our class in biostatistics, where we will use 2 sample t-tests and linear regression.
So for our data methodology, or the left half of our flowchart above, for that we have data categorization, which is having our data split into a table based upon the given descriptions found in clinical research, and also in this non-numerical data is made numerical. We also have histograms, where data is plotted based upon the unfiltered data into the categories outlined above. Central tendencies, such as the mean, median, standard deviation, variance, IQR, minimum, and maximum calculated. In addition to outliers, which are calculated, they're found in the overall cost and the BMI. Only the cost of outliers were removed, as the BMI outliers were not outliers when considering the category of a BMI of over 35. In addition, we have the initial description. The data has the central tendencies published in a chart and then analyzed. And we also have our central tendencies recalculated and our final description, which was our data being reassessed with the change of our outliers being removed and our chart being republished. And then we sent our data to biostatistical methods. So for our biostatistical methodologies, or the right half of the flowchart, we have data normalization, which is filtering our data and having z-scores performed using the formula on the following slide. In addition, we have our 2 sample t-test. So we found that a 1 sample z-test was not the most effective way to utilize the data given. If the p-value is less than 0.05, then the difference in the categorical means is significant at a 95% confidence interval. This was run across the data sets, and several significances were found. Continuing with our biostatistics methodologies, we also have data normalization, which was our z-scores performed on the 3 categories of age, BMI, and children. We've listed our formula that we use to calculate our z-scores here. And these tests were performed across all 3 categories using their respective values from mean and standard deviation. So continuing more, we also have a linear regression that we did. This was run on the BMI categories that offered continuous values to compare to the charges. This was chosen as the clinical background pointed to significance with the changing BMI of patients. Linest and a graphing software were used, R&R squared were calculated, and the coefficient of determination was determined to be insignificant, below 0.7 for all the categories. And also we decided not to use ANOVA, as literature pointed to more significance in category by category analysis and not a generalized comparison. So for our histograms that we made, these are histograms of our data for age, children, and BMI. These help us to get a better idea of where our data is skewed and where the majority of our patients and our data lie within these categories. So to start categorizing our data, we made 2 data tables, one when we first receive our data table 1, seen below, and another after doing an outlier check, data table 2. So here, data table 1, you can see that we took all categories, age, sex, smoker, region, BMI, children, and calculated the mean, min, max, median, standard deviation, and variation of the charges for each of those categories. And so, as was previously mentioned, we did an outlier test. We did this for children, BMI, and charges to determine whether we needed to cut anything from our data set, or whether we needed to consider anything to be cut from our data set. And so you can see here in these tables, we calculated for children, BMI, and charges. We found that there were no outliers in children, but both BMI and charges had outliers. And so from this test, we saw that we could have the option to cut some outliers. We made a chart of data points with these outliers cut from the data seen on the next slide. So here is our second data table after we made the decision to cut the outliers, even though we understood that they were more than 1% of our data. We still made the decision to cut them, and we were aware of that. So here's our second data table with those outliers being cut. And one big thing to note here is the much lower standard deviation in this table. So we also performed two t-tests. They were for smoking and sex. They were both two-tailed, two-sample t-tests. Our null for both of them was that for sex, the mean of the cost, healthcare cost for men, and the mean of the healthcare cost for women would be the same. The alternative hypothesis was that those means would be different. And so for sex, we found that our value came to about 0.4. So this failed to reject our null. Meaning that there's no significant difference between the healthcare cost of men and women. Onto smoking, our null hypothesis was that the mean for a smoker and the mean for a non-smoker would be about equal, and our alternative hypothesis would be that the means are different. And so for this value, we got one that was nearly zero, negative, or as you can see, a value of 10 to the negative 119. So this very adamantly rejects our null hypothesis. So there is a very, very clear and statistically significant difference in the mean of healthcare costs between smokers and non-smokers.
We also did linear regression tests on our data set. This slide shows the difference between BMI and charges. On the left, you see a BMI between 15.96 and 20. It had R-squared value of 0.0116. On the right, it was BMI between 20 and 25, and it had an R-squared value of 0.034. Both of these were far below the 70% required for it to be significantly correlated, so we decided not to use either of these categories. We ran linear regression across many separate categories. This is the 15.96 to 20 in a larger form, and the next one is the 20 to 25. As you can see, the R-squared there is very low, and both of them were below 70 significantly. The next slide shows the BMI for 25 to 30 and then 30 plus. Both of these also had R-squared values significantly low. On the left, it's approximately 0, and on the right, it's 0.007. So we ran linear regression for several of these. We ran it with and without outliers. You can see here the charges are limited. If we click to the next picture, this is BMI from 25 to 30, but you can see on the top there is a charging filter, and that filters out the charging outliers. But we ran linear regression with and without that filter on, and we ran linear regression across the whole data set and each separate category from the literature. The next picture here shows BMI between 30 plus, and also has a R-squared value that is below 70, so it was not significant. Here shows age versus healthcare cost. We had two separate linear regressions along with the overall linear regression. Neither of them were significant. On the left, ages under 45, the R-squared value is 0.0195. On the right, the R-squared value is 0.07. That was for ages 45 plus. We also ran linear regression here with and without the outliers included and excluded. And we also ran it across the entire data set and then the clinical categories, with each test showing limited to no correlation. So the shortcoming of linear regression, in analyzing BMI versus cost data and with the age versus cost data, no significant correlations were found. As such, less than 10% in the variation of charges, and this was for the best linear regression we found, can be attributed to the linear relationship between BMI and healthcare costs. This is insignificant and well below the statistical standard of 70% for a strong coefficient of determination. So our group, like I said earlier, checked every possible aspect of BMI versus cost. We removed outliers, we shifted clinical categories, took overall and compartmented linear regressions, and each of these methods failed to produce a meaningful conclusion. Our group decided that linear regression is not an appropriate tool for comparing BMI to healthcare costs. We were not able to determine that for age, though. Because of the lack of very young and very old patients, we couldn't say with certainty that linear regression would not work for those categories. the interpretation of our overall project. Through the t-test, we were able to interpret that there is a significant statistical difference in healthcare costs between smokers and non-smokers, which shows that the population of non-smoking people typically have lower healthcare costs. We were also able to interpret that there is not a significant difference between male and female healthcare costs, which means being male or female typically has no statistically significant impact on healthcare costs. Through the linear regression test, we were not able to determine a significant correlation between datasets. The R-squared values, or coefficients of determination, were far too low to point to any linear relationship between price and BMI across the overall categorical and outlier limited categories. This was the same for the age groups. We found several distinct conclusions at the end of this project. A main one was we found that linear regression is not always the proper resource to use for data sets, and we have to have other methodologies at our disposal. We found that t-tests are a very viable method in order to evaluate category by category, and we use this to evaluate whether sex and smoking are significant factors in healthcare cost. It's important to follow methodologies outlined above. So in our flowchart, we initially didn't follow that directly. We found out eventually that it was important to follow that directly in order to have proper data formatting. We initially didn't remove the outliers, and then we ran t-test first, which required us to come back and review the outlier testing. Another conclusion we found is that sometimes generalized mean disparities do not always point to a statistically significant difference in data sets. For example, the literature showed that females pay up to twice as much as males on average, but a t-test showed that it was not statistically significant, and that's because there was such a high standard deviation in the data set. Here's our citations. We found 4 research journals. You'll see here that we do not cite the Department of HHS or the Centers for Medicare and Medicaid Services. That's because these sources were cited within these articles, so we didn't want to double cite them. But we did have 4 very good articles that we used to find our literature, and they pointed us to the specific categories and demographic factors, and it also guided us towards the methodologies we use.